So I want to know that from the time I leave the room, like typically, I would say maybe average like 15 minutes. Let's say, docs, your expectations should be, I should be in and out of this room once I sit down to start prepping this crown in about 15 minutes. Today, when you're having assistants do that on not real patients, I mean time-wise.
Well, average-wise, most of them were just cleaning the temp up and doing it within a minute.
Okay.
And, that wasn't obviously cementing or checking
Mm-hmm.
the occlusion. But Tallgrass is a prime example. A week or so ago, we were in there and just kind of looking at the times it was taken. And, on the schedule, they had almost an hour to make a temporary. And so I just challenged the assistants, let's start timing it. And so they've been doing that, and they've all been prepping or, getting their temporary made and cemented on anywhere from about 8 to 20 minutes at the most now.
Yeah.
So I do challenge the assistants to do that, to make sure that you're holding each other accountable for is timing the assistant.
Yeah. I agree. I mean, if you give an hour to make a temporary, it's going to take an hour. So we get out of dental school and it's like, well, you need an hour and a half to do a crown prep. So we schedule an hour and a half, and it's like, but why? Why do we need an hour and a half? We don't. I mean, we consistently, unless we're doing multiple teeth and things like that, we consistently schedule and are usually done within an hour or less from the time anesthetics given, prepping, scanning, and the patient's, temporaries and patients out the door. So if you're not at that point, challenge yourself and say, do I really need an hour and a half? Just start taking 10-minute increments off of the time. And a lot of the stuff, the assistants, again, it's not necessarily your fault. It's just, hey, we've been given that much time. So you find things to do to make it last an hour and a half. If you're given an hour, it's not to make you guys, your job harder. It's actually going to make it easier. You're going to get through the stuff quicker. You're going to learn how to be more, efficient and quicker at doing this type of stuff. So I would challenge you guys that, being an hour should be about enough time. Yeah. So docs, hold your team accountable, and, they'll do it. They know how to do it, and they'll slowly appreciate, having almost less time, because there's just so much wasted time. The last thing we want is to leave the room. It's 15 minutes, crown prep, and then I look in my room and an hour later that patient's still in the room. It's not efficient. So, like I said, we strive to be like an hour or less. Sometimes we're done in 40 minutes for a single. If it's multiple, then maybe we'll stretch that out, but it really doesn't take much more time to do a second, back-to-back tooth. So another thing, and hopefully you'll learn that you learned a little bit on the temps today, and I encourage you, docs, to really delegate this to your team if you're not, and challenge them to be quicker and quicker. If they need the help, you have typodonts, practice on the typodonts. But this type of stuff, that's not good. You got to be able to, if you don't know what the margin looks like, start asking your doc and say, hey, is this the margin? What is it? Where do I need to shape it? Because if you have all this flash, that tissue is not going to be happy. So when you take those temps off, you're going to have tissue that's bleeding, and then you're almost always going to have to get a patient numb and get in there and use Hemodent and things like that potentially risk bonding issues and things like that you don't want to have happen. So making it as contoured to the actual margins and smooth as possible. And that's really the biggest thing, is like right interproximally, where you can just have it sitting on that papilla and making it really angry and fired up. I think you guys, assistant wise, the more and more you should be, like I said, you should be done in roughly, like 20 minutes or so.
Yeah.
I think that's probably a good thing to shoot for. Yeah, and if you're not timing in your office and you're wondering why things are slower, start timing, and you'll find a lot of wasted time. I'll adjust the closing if it's really, and then like Cindy said earlier, if I need to, I can use like a gold crown. I don't run into that issue too many times. I think, again, it's maybe sometimes just fearfulness of thinking you're reducing it too much. I would say if you can reduce maybe that cusp up top, that's that plunger cusp, and a lot of times I'll just tell the patient, hey, we're going to smooth out this cusp up top, so we have a little bit more clearance, a little bit more room for the restoration, and not have such a harmful bite back there. And they're most always okay with that. Cord, and then just coming in and reducing a little bit more on the margins. I always just look up above and start there. Yeah, and that's almost always where I start, so I don't have to necessarily take it deeper below the margins if I don't have to. I always want to try to keep things high and dry. So actual crown try-ins. So there's a lot of issues that you can have, especially if this is something that your team is doing and they're not used to doing it. But I do encourage that your team does this. I don't actually do any of this anymore unless it's really a struggle. But one of the biggest things is if concerns is you try it in and you start just checking occlusion before and you start reducing top of the crown. I've seen that too many times before you actually check those margins and make sure that the crown is fully seated. Because you can imagine if you put the crown in and it's not fully seated, well, yeah, it's going to be high. So then what's happening is it's either the contacts are too tight or, you know, the internal surface of that crown isn't quite fitting. Maybe there was a sharper edge or something like that wore away on the model. So always make sure that your margins are sealed, your contacts are good before you ever start trying to reduce the occlusion on these crowns, because then you're almost always going to have to send something back or have a hell of a time, you know, polishing that thing back up. Does that make sense? I mean, are most of the assistants, are you guys doing the initial process of trying the crowns in and getting everything ready, and then most of the docs are just coming in to seat it? To bless it. Yeah. I mean, there's occasions like, you know, when you came into my office, we had some hellish reduction on that tooth. And, you know, that's something you got to look at. Is your assistant having to take forever to reduce? And look back, maybe it was something that when I prepped, like, did I not prep reduction enough? Did I, you know, those are always ones. And I encourage you with the iTero, the good thing is you can go back and log into my iTero, log in and just look at that prep that you sent to the lab. And so that's a good way to help kind of catch things that maybe you're doing wrong, because there's still times where I've prepped something, I think it looks good, and then maybe I still didn't either reduce it enough, I didn't give the lab good enough prep, and then we're adjusting the hell out of a crown or two. So, but that's I think that's probably one of the biggest things, is just not verifying fully seating with x-ray before adjusting occlusion. So always make sure that it's fully seated before you ever start marking it with paper and reducing that thing. And then occlusal adjustments, you know, I think this is the biggest thing that we always get into. We talked about earlier with composites, is just trying to convince the patient that it feels good. Go through, and I mean, when you see like these big like areas that are blotted out in the middle where it's almost like a bullseye, like, you know, that's too tall. There's still occasions where I'll look, and the same thing with we just talked about with the, you know, second molars. You may look and that tooth up above it, below it has like a huge dagger cusp, and it's one of the reasons the restoration that was in there originally failed. So I always, you know, again, pave ways. I get permission and make sure they're okay with it. I've never had anybody say no, and just make sure they're okay with me smoothing and rounding that cusp, because one of the other things, you don't want to start reducing a ton on that tooth as well, because then you start getting that material thinner, or you start introducing, you know, cracks and things like that into the material. But again, that could be something more that it wasn't seated all the way, or that you just didn't have enough reduction from the get-go. Again, anatomy and polish. So we don't want to be adjusting a ton, because then you start taking all the anatomy out of the tooth and you start leaving it really flat and unpolished, and then it just is not going to last as long. So if you do have to reduce, always come back in, making sure that you are polishing that up and making it, you know, shine and gloss as much as possible. Cement handling. I don't know if anybody's still mixing, but, you know, one of the good things about the cement handling nowadays is the materials that we use. We can put it in, we can seat the crown, and we can tack cure from the buccal and lingual. When I say tack cure, I mean just 2 or 3 seconds on the buccal, on the lingual, and then you're just peeling that cement away. Okay, so that's a quicker, cleaner cleanup, and you're basically just, it peels. I mean, it peels from the buccal and the lingual. You don't have a ton of stuff in between. Cure it, peel that off, go through the contacts, make sure there's nothing in between stuck there. It's quick and easy. And also, one of the other things about the material is if you can tack cure it, get that initial set and seal, then you're not having the patient bite on, you know, cotton, things like that you introduce potential shifting of the crown, you know, if they're biting into it. But also, too, you're not having it sit back on like a second molar where it's just getting soaked in saliva while it's setting. So if you can tack cure it, get it cleaned up, really quick. I mean, this part of the equation does not take very long. Yeah, that's true. So, I mean, obviously following instructions, but even the Nexus RMGI, I mean, that's a tack cure. That's a nice cement. I know it's a little bit more expensive, but that's what we use a lot in most of our cases, and we get a good cleanup. But just making sure you're getting in there. And again, the biggest thing is making sure you're not blocking out the contacts and locking cement in there, and making sure you're not leaving anything along the margin. So always getting a second x-ray to make sure you've got everything. So, and always one good thing to do, and it took me a while to learn this, was make sure, and I always talk to the patient about it when I'm seating the crown. So I've seated it. We do the initial get-go of clean everything up, and then so I can get out of the room without them talking to me a ton, because it's usually, I want to be in there. I mean, honestly, I want to be in there in just like maybe a couple minutes at most. Come in, seat the crown, set it up, get the heck out of there. So while I'm doing that, I'm telling the patient, it sounds bad, but I mean, you should not be in there. Crown seats should take 20 minutes total time. You know, I'm telling them, hey, you know, this is, if we haven't numbed